Hello guys, this is Vikrant and Sengar, pursuing MBBS from GRMC Gwalior, now presenting a beautiful lecture on the great topic, that is the Gastro-Esophageal Reflux disease. So, let's get started. So guys, let us discuss the brand new topic, that is the Gastro-Esophageal Reflux disease, and today we will go for the part 1 of GERD, followed by the anatomy and the physiology of esophagus and the risk factors, etiopathogenesis, clinical features and the complications of GERD, which are driven from the anatomy, physiology, pathology and the medicine, right? Subsequently, in the part 2, we will go for the diagnosis and the corresponding management of GERD. Okay, so we will go for the anatomy, and the whole of the anatomy of esophagus have been discussed in my previous videos. You can go for that, but now we will go for the relevant topic, that is the upper esophageal and lower esophageal sphincters. An upper esophageal sphincter is playing the anatomical and a physiological role. Anatomical stands for, that is the narrowest portion, that is the narrowest portion of GIT, right? So it is playing the anatomical role, followed by the physiological role. Since this is the area of high pressure, the pressure of more than 60 mmHg, that's why it is playing the physiological role here. Followed by the lower esophageal sphincter, which is playing the physiological role as it is having the 6 to 26 mmHg of pressure. It is lesser than the upper one, but still it is significant. Then we will discuss the muscles forming the upper esophageal sphincter, that is the thyropharynges and the cricopharynges. Okay, so these are the oblique fibers of thyropharynges and these are the horizontal fibers of cricopharynges, and that is having a triangular space in between, that is the Killian's dehiscence, and the outporching, the pathological outporching of this Killian's dehiscence is called as the Zenker's diverticulum. Now we will go for the muscles forming the lower esophageal sphincter, that is basically formed by the thickening of circular smooth muscles of lower esophagus, right? And if there is failure of relaxation of LES, that results into the achalasia that we have discussed in our previous sessions, and if there is excessive relaxation, that results into a pathology, that is the GERD. Now we will discuss the physiology of esophagus, that is basically peristalsis. And when we have swallowed something, that food bolus traverses whole length of esophagus with the help of peristalsis, right? And when after deglutition, when the food bolus touches and enters into the upper part of esophagus, that produces reflux and that produces peristalsis, that is basically the primary peristalsis, which is propulsive and progressive in nature, right? And through the help of which the whole food bolus is traveling through the whole length of esophagus. And when the primary peristalsis is not able to push the food, the left out food bolus is able to trigger the secondary wave of peristalsis, and secondary wave will push out this food bolus to the stomach, and this is also progressive and propulsive in nature. And tertiary peristalsis is not propulsive, not peristaltic and not propagative in nature. Rather, it is just spasmodic contractions of esophagus, and that is more commonly seen in the elderly population. That's why it is called as the presbyesophagus here. Now we will discuss the factors maintaining the tone of lower esophageal sphincter here, right? And the most important factor is the intra-abdominal length of esophagus, right? So this is the intra-abdominal length. This is the intra-abdominal length, that is basically 3 to 5 centimeter. Okay, that is the most important factor maintaining the positioning of esophagus. So second most important factor is the pinching effect of right crura of diaphragm here. So this is the stomach and esophagus, and that is the right crura of diaphragm here, which is holding the LES to its own position here. Okay, so this is the first factor and that is second one. Third factor is the angle of His. This is the angle of His, okay, the angle between this LES and the fundus here, right? So the fourth factor is the arrangement of gastric folds. These are the gastric folds here, maintaining the LES to its own position here. So now we will discuss the risk factors and the etiological factors causing the GERD, right? So we have two categories. Number one is a drug section and second one is a food section here. So the most common foods which are causing the reflux of the content into the esophagus, number one is a chocolate, followed by the coffee, and alcohol, smoking, fatty foods, citrus foods such as the orange and lemon, and followed by the spicy food materials and the peppermint as well. these are the foodstuffs causing the reflux of the gastric content to the esophagus, and thereby that is the risk factor of that. Now followed by the drugs causing this, right? Number one is the calcium channel blocker here, okay, and that is relaxing the LES, thereby causing the reflux. And nitrate is causing the same, and atropine, the M3 antagonist, causing the same thing, and the diazepam, dopamine, barbiturates, okay, these are causing the reflux as well, and theophylline, morphine, prostaglandin, and the progesterone are just causing the reflux of gastric content to the esophagus, the same etiological factors, right? So this is what the etiological factors, and now we will discuss the pathogenesis of GERD, and basically that is the onset of the etiological factors. The onset of etiological factors that results into the incompetent LES. Okay, so there is risk of the reflux of gastric content to the esophagus, and that is causing the reflux esophagitis, right? There is injury to esophagus, and this is resulting into the erosion and the ulceration of esophagus, and this is causing the fibrosis during the chronic inflammation, and that is resulting into the stricture formation. These are the complications, right? Complications of GERD. Okay, so stricture formation is there, and which is followed by the columnar metaplasia, the intestinal metaplasia to withstand the gastric acidity. So there is the metaplasia, that is the intestinal metaplasia of lower part of esophagus to withstand the gastric acidity. And the prolonged exposure to this same condition that results into the increased risk of getting adenocarcinoma in the near future. Now we will discuss the clinical features and manifestations occurring in the patient of GERD. Number one is the retrosternal chest pain, that is commonly called as the heartburn, right? Heartburn is there, number one feature, followed by the epigastric pain is occurring to the patient here. Third one is the regurgitation and reflux of gastric content to the esophagus, and that is the third manifestation. And the fourth feature is the sour brash, right? And there is the sour alteration of taste to the patient is there. So fifth feature is the morning coughing is there, and that is because of the tracheitis component. Okay, so irritation of trachea, and that results into the coughing reflex to the patient, right? Sixth one is there is the erosion of enamel. So dental caries are more common to the patient, and followed by there is the laryngitis, pharyngitis, and the tracheitis is there to the patient. And the eighth feature is there is hoarseness. There is the hoarseness of sound here, right? And due to the inflammation and irritation of recurrent laryngeal nerve is there. So this is what the clinical features. So now we will go for the staging of GERD. That is basically written in the book of pharmacology, that is KDT, and we will go for the staging system here, and that is the stage 1, stage 2, and stage 3 of GERD, right? And these are graded, and these are classified on the basis of the frequency of heartburn to the patient on the weekly basis. So whenever there is the less than 3 episodes of heartburn is there to the patient on the weekly basis, we are just categorizing it to be the stage 1, and that is associated with the onset of risk factors, right? So risk factors are there to the patient, and that is categorized as, and that is graded as the stage 1 of GERD, followed by the stage 2 of the same. So in the stage 2, whenever the frequency is more than equal to 3 of heartburn in 1 week, that is graded as the stage 2 of GERD, and this is associated with the nocturnal awakening, and the right esophagitis may or may not be present to the patient, and followed by the stage 3 of heartburn. So the symptoms and the heartburn is occurring to the patient on the daily basis for the chronic time period. So this is what the stage 3, and all these features that we have discussed previously are present in this patient. So the disturbed sleep is there, esophageal erosion, strictures, hoarseness, and the dry coughing is there, and patient may be asthmatic, right? So now we will go for the complications of GERD, our last topic of today's session. So number 1 is the Barrett's esophagus, right? And whenever there is chronic exposure of mucosa of lower end of esophagus to the gastric acidity is there, and that is causing the irritation, and that is causing the metaplasia of mucosa of lower end of esophagus from the stratified squamous non-conified to intestinal columnar epithelium. So this is what the Barrett's esophagus, followed by the stricture formation. Whenever the chronic injury is there, that is causing chronic inflammation, and that is causing the fibrosis and stricture formation to the lower end of esophagus is there. And third complication is the adenocarcinoma of esophagus. Basically that is the prolonged case of Barrett's esophagus that is turning into the malignancy, that is the adenocarcinoma of lower end of esophagus is there. And fourth one is the sinusitis. So fifth complication is the regurgitation of acid into the lungs, right? And that is causing the aspiration pneumonia and aspiration pneumonitis, and that can even be further complicated into the abscess formation is there into the lungs, and that is what the fifth complication. And sixth one is there is the bleeding and ulceration of the esophagus can be there, and that will result into the hematemesis. And seventh complication is there can be the adult onset asthma can be there, and which may be associated with the eosinophilia, right? So this is what the complications of GERD, and thank you for watching.
If you're just having any doubt or inquiry, you can go for the comment section below, hit the like button for the sake of the motivation, and don't forget to subscribe. Pressing bell icon will give me some vibe, and we will meet at the part 2 of GERD. Till then, keep integrating. Thank you.